We're now going to hear from Darcy Burbage from the Christiana Care Health System in Newark, Delaware, not far from here. And Darcy's going to talk to us about navigation from the Navigator point of view. And she has been an oncology nurse for a couple of years. I won't tell you how many. And has worked in developing their cancer navigation services, and she'll tell you her story.
Good morning. It's my pleasure to be here today. I could probably rename this presentation to Putting Evidence into Practice for Navigation, and just listening to Dr. Freeman and Electra, just how our navigation program kind of took on what they have developed in far as the navigation services, as far as the outcome measures as going as well. So thank you again for allowing me to present today. Oops. So in my navigation career, when I began many years ago, there's been multiple iterations of the term. So I wasn't known as a navigator back almost 20 years ago. So I'm so glad to know that we finally have decided upon a term that really captures what we do as nurses working in this role. When I was researching this presentation, just looking at the titles that I have had, and also in looking at the literature, there must have been about 15 different titles that I came across in putting this program together. So as I said, I'm glad that we finally are known as navigators. Something. Am I breaking this layer?
Just have to be more heavy hands.
Oh, sorry. Thank you. So regardless of what you call your navigator, the goal remains the same: providing individual assistance to the patient and their caregivers, reduce barriers to care, as we've heard several times today, as well as increase access to medical and psychosocial care across the entire continuum. Paraphrased on this slide are the definitions of oncology nurse navigators and lay navigators according to the 2017 Oncology Nursing Society Core Competency Guide. I'm not going to go further into the core competencies, as I know Mandy will be doing her presentation later today on that. The roles of the clinical and non-clinical navigators are both extremely important in assisting our patients living with cancer. The most robust navigation programs tend to have a combination of both roles and work very closely together. In the literature, several common themes have emerged in regards to specific training and responsibilities for nurse navigators as compared to non-clinical or lay navigators. In my practice setting, we're required to have a BSN, and we're all required to be oncology certified. In our lay population or peer navigators, most of them are trained volunteers, grant funded, and some of them do have a history of cancer. In some cancer programs, lay navigators work in specific areas of the community where they live and are trusted, such as community health centers, churches, or in high-risk zip codes, as we know that there's a history of low follow-up rates. So we want to help facilitate access to care, and generally those peer or lay navigators work very closely with the cancer center and oncology navigators in their practice. Lastly, but certainly not least, is the role of the oncology social worker as a navigator. According to the AOSW, social workers may serve as navigators, and their primary responsibilities are to perform initial and ongoing psychosocial assessment, providing social work assessment to patients and their caregivers, as well as linking patients and caregivers to community resources. I'm aware of several social workers who serve in navigator roles. In my cancer center, they're not identified as navigators, but certainly we assign them to different patients based on their diagnosis, and we work very closely with them. In the literature, I came across some social workers who work as navigators in our young adult population, in breast care, in survivorship, as well as in the hematologic population, looking at the stem cell transplant population. If we were to look specifically at the role of the nurse navigator in practice, one of our main roles is to provide patient and caregiver education regarding available resources, including clinical trials, symptom management to help reduce preventable hospital admissions and readmissions, as well as ensuring timely access to care, and certainly looking at quality improvement and performance improvement studies, such as reducing turnaround time, no-show rates, as we talked about, ER, and admission rates, looking at process maps to help the navigator as they develop their disease-specific program. In addition, nurse navigators are sometimes called upon to provide education in their community or support groups as they really become known as the expert in a disease-specific site that they work in, or as one of the specialty areas, either in palliative care or in survivorship. Depending upon your facility and patient volume, as well as availability of support staff, some navigators may be responsible for non-clinical duties, such as scheduling appointments or pre-authorization for certain things. I know early in my career, we didn't have access to a lot of support services, so I did a lot of those responsibilities or had a lot of those responsibilities. But as the navigation program grew and our patient population grew, we were able to add support services that took away those, clerical burdens from the nurse. So we were able to spend more time with our patients and really practice at the top of our license. However, I recognize I'm very lucky, so that may not happen in a lot of settings, or at least not yet. This reference may be a little dated, but I think still it's very pertinent. I often get questions if the responsibilities of the nurse navigator differs between a large academic setting as compared to a community center or in a rural practice. However, they really shouldn't. But there are more challenges for the navigator who works by themselves trying to manage the care of 100+ patients at various points along the continuum with limited resources. And now, as we know, many centers are using core competencies or they're accredited by the COC. There really shouldn't be a large amount of variation between practice settings. Most clinical navigators are required to be certified in oncology or at least get that certification within a set amount of time, or they're required to be certified as an oncology social worker. As we know, 80% of cancer care is provided in the community, so it's as patients want to stay close to their home and families. That being said, those of us who live or practice in more rural settings, it's exciting to me to see how telehealth could perhaps be used more in those practice settings. Regardless of where you work or practice, it's definitely a challenge with the number of patients that we're asked to navigate from throughout the continuum of care, in addition to the number of complexity of treatments that patients are now being faced with. And as we have mentioned a few times, the socioeconomic concerns of our patients that are continuing to be a challenge. So key to any role of a navigator, for those of you who are in the navigator role or are just starting out, you really have to be extremely organized. You have to be able to multitask very well as reprioritize almost continually. And always think about one step ahead. Think about those patients, all right, this person's having surgery, they're going to have their first chemotherapy, they have some issues with barriers, are they going to make it? I always trust my gut. That's what I tell people that I'm mentoring or who are new in their navigator role. If I have a patient on my mind a lot, I just pick up the phone and call them. Just thinking about you, how are things going? Most of the time they'll say, wow, you know what, I was thinking about you too, I had a question. So trust your gut. So most of the time it's going to tell you, you really need to follow up with that patient. So I'm just going to switch gears a little bit and talk about the navigation program where I work. So here's home. Christiana Care Health System is a 1,100-bed nonprofit teaching institution in Newark, Delaware. We are halfway between Philadelphia and Baltimore, so some of our patients go to Penn for second opinions or some of the NCI institutions down in the Baltimore area for opinions. The Helen Graham Cancer Center is at the bottom of your screen. near the road down there. It's a 200,000 square foot building that houses our outpatient adult oncology program. We also have a young adult transitions program that we work in collaboration with AI DuPont Institute that sees most of our PEDS cases. In addition to the traditional medical services, we have a library that's on site. We have a recovery boutique. There's a labyrinth. We also have a meditation room, a translational research program that's working really closely with some of the CRISPR technology. And we also have a rooftop garden where we grow different vegetables, and in the summertime, we share that as our as a family, at a farmer's market for our patients. We don't grow any medicinal marijuana. I just want to say that because Delaware is a dispensary state, but there's not a dispensary at the Helen Graham Center. So just want to put that out there. So, okay, moving on. Since housing our oncology services in a central location, we've certainly increased the number of patients seen per year exponentially. In addition to Delaware, we serve patients in the surrounding communities of Maryland, southeastern Pennsylvania, as well as parts of New Jersey. Our navigation system, program was implemented back in 1999 to coincide with the opening of our breast center. I was hired at that time and had a different title, no job description. It was just, we need this fixed, so fix this. So what I started out doing was talk to our patients that I've met along the way in my career, ask them, what helped you when you were diagnosed? What would you have liked to have had available as resources? So talk to your patients. So that's what I would say first if you're beginning the program, is find out from them what would work. Very rapidly, we found out that one navigator did not work in our breast center. We saw 3,000 patients who were recommended for biopsies per year, and what we didn't take into account, I'm sorry to say, were the patients who were already diagnosed. And those patients were finding out, oh, there's a navigator, I want a navigator. So we thankfully were able to add more navigators. My background is a CNS, so we hired 3 additional navigators, and I served as a leader to those other navigators and took on complex cases, as well as our high-risk breast and ovarian cancer surveillance program. Several years later, we were able to add 8 additional nurse navigators. We're disease specific, so there's patient navigators for our head and neck population, for our hematologic population, GU, GYN, colorectal. We also hired inpatient navigators to help improve the discharge planning process. We also have social workers. There are 6 social workers that work in the outpatient setting as well, and they rotate inpatient to help with discharge planning. We also have 6 lay navigators that work in our community health and outreach program. The majority of our lay navigators are either grant funded or partially grant funded by the Komen Foundation, through Avon, or through some of our state funded resources. They're bilingual in Spanish and Mandarin. We do have African American lay navigators as well. We also have prevention navigators in our colorectal and prostate population, as well as in our lung screening. In 2010, I took on the role of developing our survivorship navigator role, and then recently I'm in our supportive and palliative care program. So we're really fortunate to have a pretty robust nurse navigation program. This slide right here is a very high-level workflow for our nurse navigators. The green boxes on the side is how patients come into our program. Either they're identified through the prevention program, through our lay navigators. They came in with a symptom. They were admitted to the inpatient center, were diagnosed subsequently. They are referred by themselves saying, I need a navigator. I heard you have a program, multidisciplinary center. They were identified through tumor conferences or as other practices in our cancer program. And the initial visit is done by one of our disease-specific nurse navigators. And then, how they provide their care is listed in the white boxes in the middle. In our survivorship and palliative care programs, since there's only one navigator in those settings, and we have such a large volume of disease-specific navigators, our navigators follow the patients throughout the continuum of care through survivorship, through palliative care, through end-of-life care, through recurrence. So the palliative care as well as the survivorship navigator are more so consultants. So they meet with patients who have complex needs, who they've met with a disease-specific navigator, and they just need an additional layer of support or another eyes on the patient, so to speak. The caseload of our navigators varies. We see the majority of our patients are breast cancer, so about 7 new breast cancer patients are diagnosed per week. Open cases vary between navigators, anywhere between 50 to 100 at any point throughout the continuum. They're based on many factors. Certainly the higher the acuity, the more time that we spend with our patients. So, and it's dependent upon not only the stage of treatment and the multimodality treatment that may be recommended, but also the socioeconomic factors. Do patients have insurance? Are they underinsured? What's their living situation? Are they homeless? What other comorbidities do they have? Not only medical comorbidities, but they have a history of substance abuse or psychiatric disorders? Who's their support system? Do they have a support system? Are they a single parent? Do they take care of elderly parents? Is their partner also sick and they're taking care of them as well, and now they're diagnosed with cancer? Who's going to take care of that other person in their family? And certainly we want to look at the health literacy, and is English their primary language or not? These are just a few of our nurse navigator-led patient outcome measures. Since incorporating or implementing the role of navigation, we've been able to maintain our patient satisfaction and provider satisfaction scores. Our breast biopsy turnaround time has decreased from 18 days from abnormal finding to biopsy proven results to 5 days. We developed a comprehensive lymphedema program that we were able to, provide a greater than 80% reduction in volumetric measurements. And also, as compared to our navigated patients and those who weren't navigated, our ED visits, admissions, as well as 30-day readmission rates were almost cut in half by having a navigator incorporated into their process. So just to summarize, as I'm coming down to the end of my presentation, some lessons that we've learned along the way. Certainly, there's not a one-size-fits-all approach to navigation. If you're developing your program, you want to anticipate growing pains. You want to think it's going to work out perfectly, because why wouldn't it? But definitely, there's always some growing pains. When you start out, ask your patients. Find out from them what would help them, what would work. Put all these ideas down. Talk to your providers. Talk to your other stakeholders. And also define the population as well as the role of the navigator. You may want to start out small at first as a specific disease site or, specific continuum, part of the continuum, survivorship, palliative care. I didn't address this, but in some programs, they're also beginning to incorporate the role of the oral adherence nurse navigator. So you want to utilize existing resources. Look at the Oncology Nursing Society, the resources they have. If your center is accredited by the Commission on Cancer, look at the resources that are available there. Once you begin your navigation program, start to look at specific metrics, what you want to measure, and begin tracking them and develop a system to track that right away. And also communicate. Communicate back to your providers, communicate back to your patient advisory council about what's working, what we're going to improve, what we're going to switch up a little bit. I always like to say, let's try it. Let's try it for a couple weeks and see if it works. If not, we can go back and revisit it. But don't be afraid to try new things. It's ultimately going to help our patients. So if somebody has an idea, we go for it. And finally, we're all here to learn from each other, to improve the care provided to our patients. But as Electra and Dr. Freeman says, how can we balance the volume and acuity of our patients with the limited resources that we're all faced with? So just thinking outside the box a little bit, how can we maintain that, individual navigation resource and that, connection we have with our patients? Can we perhaps utilize group visits, have patients come in, and then we start to work with them individually. In our pre-vivor populations, but those who are at high risk, or in our survivorship population. Can we utilize telehealth more, not just in the rural setting, but perhaps in the urban centers as well? How about technology? You know, we all have our cell phones. Some of us are tweeting out the presentation today, looking at, you know, being around the innovation table. So we really need to be at the table with those people who are really good at tech things. So what do our patients need? What do we as clinicians want to do? So they're the experts. We are the clinical experts, so working tandem with them as well. Social media, as I said, Facebook, Twitter, different podcasts, apps that are out there, Cancer Round, Smart Patient, Stupid Cancer. There's a whole bunch of them that are out there that our patients are using. In our supportive and palliative care program, we recently started using FaceTime as well as Skype for family meetings rather than just conference call-in lines, because some of our families are throughout the United States. So also collaborating with our non-oncology colleagues, we need to do that a little bit better. So to be continued. So thank you all for your time and attention.
Thank you so much, Darcy. That was an amazing story of what you've accomplished in not so many years, and hearing it from somebody who's actually done it and been there through the continuum is very inspiring.